Hello, hello. Can anybody hear me? Hey, Manuel, can you hear me?
Hello, John.
Hey, Manuel, can you hear me?
Yes, I hear you.
Okay, how you doing?
Good. Already it's cold in Moscow.
You're in Moscow now, right?
Yes, 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 I am.
Okay.
I'm back home.
Okay, so you got your camera working, right?
Yes, of course.
I don't see it on. Is it on? It's not on now. Hello, Gabriel.
Now you see me.
Oh, there you go. There you go. Yeah, nice background. Let me get my off. So you work today?
Yes, yes, I work today.
Because right now it's 1 o'clock there, right?
Yeah, 12:46.
Yes, nice background.
Thank you, thank you.
So how's your development going of your prototype?
Which one? You mean the model?
Yeah, the skull, the brain.
It's a stop now by founding, because I am learning by myself, buying material, trying best material, but it's a process. Now I know. Sorry.
It's a procedure, yeah.
Yes. I find good material. I'm gonna show you. I'm gonna show you the last material I find.
Okay.
It's called, this material can be good. This material is very good for make different stuff. I have this idea, but I need to buy more material and see. But for example, look this sensation this material can give. I'm gonna show you.
Okay.
This one. Look this one. The camera here. You see this one?
Hold on. Oh, okay. That's the liquid, right?
It's semi-liquid, you see?
Yeah, it's a semi-liquid?
It's like hydrogel.
Hydrogel.
Yes.
Okay, that has the properties what you need, right?
Yes. But this one I can use like a tumor, you see? Because you can remove this one, but you can put it together. But the idea is I need one. I have another one, but this is spoiled. I see it's spoiled because the office is very hot. But the other one material, this one material, it's like water, and you can aspirate. And this is what I need. I want different material to try different pathologies. That's the goal. Different material, different pathologies, and I think that's all.
Oh, okay. So very good. You're learning about materials.
I need to.
Well, you know, I did a little bit of 3D printing webinars, and I see that the technology of 3D is very dependent on material technology.
Yes, of course.
That's the thing that determines what you can do is material technology, how they're improving on material.
Yes, that's true. But now we have so many different kind of material, and you can play with different kind of material and make a lot of different pathologies. Because, for example, I make the vessels. I make these vessels. These vessels have lumen inside.
Oh, okay.
They are not printing; they're handmade. But I am improving myself how to do it and to make very easily. But the main point with the vessels is to have this sensation like a real vessel. And when you put the clip don't just smooth, go out.
Oh, okay.
To have the lumen for the pulsation. But it's something, I got it.
Okay. Hello, Amir. Can you hear me?
Yes. Hello, Dr. John. How are you?
Welcome.
You have a good topic today.
Yeah, Amir.
Yes.
I don't see you in the panel. Are you in the panel now? Your camera is not on, right?
Yes.
Because I don't see your camera on. I see your microphone on.
Yeah, I don't have it. I know.
Oh, okay. That's okay. You don't need one.
Okay. If it is possible, I can on the camera and.
Yeah, you can try it.
Okay. Thank you. Oh, yes.
Oh, okay. Oh, okay. So you're in now, right? You're in now, Amir, right? I can see you in there now. I think Zoom is changing the platform. Hello, Gabriel. Welcome. Where are you from, Gabriel? Oh, there you go. There you go. Welcome. Gabriel, are you there? Your camera was there before. I don't see it now.
Sorry, John, you say something?
Yeah, I was talking to Gabriel as a panelist. Who started in 9 minutes.
Yeah. Excuse me, can I ask a question?
Yeah, sure.
Thank you. Dr. Manuel, you talked about the method of manufacturing the vessels, yes?
Sorry?
You said that you manufacture the vessels, okay?
Yes.
Yes. The method is additive manufacturing by 3D printing, yes? Or not?
No, it's handmade because the problem is with the 3D printing is very expensive. I'm gonna show you one, for example, this one is 3D printed, you see?
Yes.
Yes, you can use it for teaching. This is resin, but you can have 3D printing by filament, but the quality of the printing is no good. If you want to teach or to teach the patient, yes. If you want to teach the residents, this one can be better. But
Okay.
if you want to practice like clipping aneurysm or putting a coil, this is the better one because this is silicone one hollow. It's hollowed inside. You can put a liquid inside. Let me see if you can see the lumen here.
Yes.
But the point is, you can see the lumen of in this one. Let me see because it's broken here. But in this one have lumen. You can clip it, and if you injure the vessel, it's gonna break and it's gonna bleed.
Okay. Yes, this method is based on stereolithography. Yes.
No. For example, the method I use for this one with silicone is casting. I make a casting, a negative casting.
Casting. Okay. Yeah.
After printing, I make a negative casting of the vessels.
Investment casting. Yes.
Because otherwise the process can be more expensive and it's going to take more time.
Okay. There is one note, and I can, if I can say that.
Yes.
My major is biomechanics, and you said about the behavior pattern of material. Yes.
Yes.
It is very important for surgeons, and I would be happy if you have a research about this topic, because in biomechanics we deal with stresses. Stress is the something like pressure that is force per area. Tendency stresses, compressive stresses, strains, that is the different in dimension, and something like that. If it is possible, in the next sessions I can talk about these topics. And
yes, that can be very good.
Thank you.
My pleasure.
Thank you. It's the benefits of these sections with the aid of Dr. John that we can find each other.
Yes, that's true. That's
Yeah,
true.
yes, that's the benefit of this platform.
Thank you.
Connect people with each other.
Right now, bioscientists talking to a doctor developing something that needs
Yes.
some biochemical background.
Thank
Needs
you.
background.
Thank you very much.
Because you heard what I said. 3D is very dependent on material technology. The development of material technology is
Yes.
is improving with the materials they can use and the things they can do.
Of course, yes.
And when there's an advance in that, it helps all of 3D printing.
Yes.
So this is your background, huh? Biochemistry or biotechnology.
Thank you. Yes.
Okay, we got 3 minutes, Manuel. You're muted, Amir. You're muted.
Who, me?
No, Amir was muted. I think he was trying to talk. You know, Manuel, if you want to give a presentation on your prototype to the Latin community, again.
Yes, of course, of course.
Yeah, because I'm working with some students from Peru that are very good with technology, good with social media.
Yes, we can do it. We can do it.
Yeah. They'll be very interested to hear that, what you're talking about. Very active in Cusco, Peru.
Cusco, Peru. Yes.
Yeah, that's the group I work with. There's a team. They're very good when we have a Spanish conference. So it's very, they help promote it, and they use Instagram. Instagram is getting more popular. I guess you probably grew up with Instagram, right?
I need to open Instagram. I'm very lazy with that.
Yeah, I don't do it either. I'm trying to learn it. I bought a book on it, but I haven't opened the book yet.
I am very lazy with Instagram. With social network, I am like kind of lazy. You know, I'm very busy too.
Okay, ready to
social
start?
Network.
Ready to start? Ready to start? Are you ready to start?
Yes, of course.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. In the background, home of Neurosurgical TV. We have a webcast today with Manuel Encarnacion, originally from the Dominican Republic. Now he's in Russia, and he's going to give a presentation on Cisternostomy in Russia. Welcome, Manuel. It's all yours.
Hello, thank you very much, John. Thank you for the opportunity. So today we're going to talk about the Systemostomy cases here we made in Russian Federation. See the prognosis and the future of this technique here. Okay, I'm going to share my screen now. Okay, do you see my screen, John?
Yes, perfect.
Okay. So the first we need to talk about before I talk about Systemostomy is the traumatic brain injury. The head injury is among the most serious type of injury, both in terms of fatality and long term of implication for the survivors. The traumatic brain injuries treatment can be complex and very expensive. After the clinical examination, the head injury is most commonly subdivided in mild, moderate, and severe traumatic brain injury, according to the Glasgow Coma score. So the decompressive craniotomy can be, we can say, is one of the first, or maybe the first kind of surgery of the human being. You can see here, we have a cranial trepanation of the times 10,000 years before our time, before Christ. Also, there are records of trepanation after trauma in the first century by Hippocrates. In 1991, Kosher, and in 1903, Cushing also reported the use of large decompressive craniotomy for patients with traumatic brain injury. So, although there is current compilation, a compelling of evidence that decompressive craniotomy produces the ICP, and the undersize decompressive craniotomy is associated with a very poor outcome. Additional high quality studies are needed to inform all the aspects of the decompressive craniotomy as applied in the clinical practice for the severe traumatic brain injury. We have two studies. One is the rescue ICP trial of decompressive craniotomy for traumatic intracranial hypertension, and the other one is DECRA. DECRA is the decompressive craniotomy in patients with severe traumatic brain injury. These two studies, however, the result has served as a simple interpretation. The decompressive craniotomy remains controversial despite the publication of these high-quality trials. In the fourth edition of the trauma in the Brain Trauma Foundation Guidelines of Management of Severe Traumatic Brain Injuries was published in 2017, and the main chapter provide two levels, 2A recommendation or subject of the decompressive craniotomy. One of these recommendations say a large frontotemporal parietal decompressive craniotomy of 12 centimeter or 15 centimeter and in diameter 15 centimeter in all is over a small frontotemporal craniotomy. Decompressive craniotomy is recommended to reduce the mortality and improve the neurological outcome in the patient with traumatic brain injury. So what about here in the Russian Federation? According to the National Institute of Statistics, the number of patients hospitalized with traumatic brain injury only in Moscow is from 13,000 to 15,000 patients. To 15,000 patients per year. Predominantly, they are male. It's a lot of patients. It's a huge amount of patients. This statistic is, you can see the year, but this statistic is for 5 years. Every 5 years, the National Institute of Statistics take all this data. So in the Russian Federation, the guidelines are the same. We have big decompressive craniectomy. And I left all these papers talking about the guideline here. You can see it here, the guideline of the Russian Federation for traumatic brain injury patient. So now we need to talk about the history. We're gonna talk a small topic about the history of the microneurosurgery. Start in the 16th, okay? Jackson and Suarez, they published a very big famous paper about the microsurgery in small blood vessels. But the first model was developed in Burlington by the SACE company. And we have here the first type of microscope for operation room. This microscope, as you can see, have a camera here, okay? A Nikon. You can see this is a very good editorial written by Professor Jacksonville about the consideration of the history of the microneurosurgery. I leave all the link and all the reference in the end, okay? So, as you can see, the implementation of the microsurgery has revolutionized every aspect of the neurosurgery: the vascular neurosurgery, peripheral nerve neurosurgery, spinal surgery, neuro-oncology, pediatric surgery. But what about traumatic brain injury? What about the trauma? Why we still need to make the trauma surgery the same way as the 110 years ago or 200 years ago? Okay, why? This is one of the issues we need to solve. As you can see here, cystonostomy is nothing new. There is a lot of papers already talking about the cystonostomy and make a comparison study of cystonostomy with the cystonostomy plus decompressive craniectomy or cystonostomy alone, okay? You can see here, for example. As you can see here, we have implementation of the cystonostomy and adjuvant to the decompressive craniotomy for the management of traumatic brain injury. And this combination have very good results. Okay, so what is that? What is cystonostomy? As I say, it's not new. It's not a new technique. All vascular neurosurgeons have has been touched with the cystonostomy since the beginning. The cystonostomy as a technique can be a runner exit from the cerebrospinal fluid, from the ventricular system to the subarachnoidal system or subarachnoidal space, or an entrance corridor to the atmospheric pressure to open in the basal cistern and equalize the cistern pressure and the external one, okay, with the aim of relaxing the brain. So, therefore, there is some classification of the cystonostomy in two big categories. One is the outflow corridor or exit corridor. So this is when the cystonostomy provides the drainage from the ventricular CSF and a closed contained compartment. This includes the ventricular cysternostomy. For example, you know, the third ventriculostomy here, this one, or the cysternostomy. We have here the intentional cyst fenestration, okay, in the subarachnoid space. And we have, later we have another one, we have the inflow corridor. The inflow corridor or entrance corridor is the proper cysternostomy. This is the one we're gonna talk about. This cysternostomy is when the cysternostomy acts as a drain with the rational pathway to allow the output of the CSF to relax the brain. The same method is like we use for skull-based surgeries or microvascular surgeries. And also, as you can see here, we can categorize as a plain cysternostomy or unplain cysternostomy. Unplain cystonostomy is intraoperative brain swelling. And plain cystonostomy is when we already know what we're gonna do. We have all the equipment, okay? It's a plain surgery. So something we need to talk to understand the cystonostomy is the glymphatic system. What is that? So the glymphatic system is a network of vessels with the presence of aquaporin-4 channels. The transport glymphatic use the energy of the arteries pulsate. This glymphatic system has proven to the cerebrospinal fluid from the cistern and not for the ventricles. And not for the ventricles. Thus communicate with the parenchyma through the virtual rubbing space, okay? So after we understand that, we need to know about the CSF shift edema. In Spanish, it's a translocation. Things call it translocation edema. This occurs because, as we say, with the glymphatic system, when there is an injury, this liquid, this CSF, move from the subarachnoid space through the virtual rubbing space. You see, virtual rubbing space to the parenchyma, to the brain parenchyma. And then that's the reason sometimes we open, when we open the dura, we open the arachnoid, and we say, oh, there is no liquor. Where is the CSF? It's because all the CSF is in the brain already. But when we open the system, this CSF going out. This is the reason why sometimes we don't see the CSF, because this movement from the subarachnoid space, the virtual rubbings, parenchyma, okay? So the question is, when I do the cysternostomy, we have a Glasgow score at admission, always at admission, 5 to 8. If we have less than 5, no, we don't gonna have a good result, because cysternostomy is not a magic, okay? It's not like gonna be the panacea. It's a technique who have proof to make a better outcome in patient. But if the patient in the beginning, we know the patient have gonna have very bad outcome by the neurological status, and there is nothing we can do. So intraparenchymal hemorrhage with mass effect, subdural hematoma with mass effect, pediatric brain injury with the brain swelling, epidural hematoma, also with the mass effect, unilateral or multiple contusion with brain swelling, with or without subdural hematoma. When I don't do it, as I said before, we have a Glasgow score less than 5, or if the patient has a very prolonged severe hypotension preoperatively, with the dysfunctional axonal injury, ischemic stroke. This is questionable because some studies have proven the cysternostomy work in this kind of patient. Okay, this is something we need to make more study and see, because the kind of edema we have here is different, because here the edema is, we have a cytotoxic edema here. This is by the lack of energy, okay? This is kind of different edema, but we need to make more studies. If we have a patient with polytraumatic patient, prolonged hypoxia, the same result. Age more than 80, hemorrhage, diastasis of ENR of 3. What we're gonna do with in the ICU, in neuro ICU, the patient should be sedated. The patient, as there is some studies and I put you in the end on the reference. With a patient with cystonostomy, have at least 1 or 2 days less time sedated in comparison with the patient who don't make cystonostomy. Okay. So the cysternal drainage management, we're gonna make a cysternal drainage, as you can see here. Okay, we can put any kind of different drainage here. Okay, height of the level of the tragus, the duration can be 4 to 5 days. You can see the volume of liquid of the CSF we're gonna accommodate per day. We can use as the hyperemolar therapy. It's not like a regular protocol, okay? Normothermia, normal ventilation. So now we're gonna talk about the cystonostomy, how we do it before make the presentation of some cases. So you can see this is a very beautiful picture of the cystonostomy. One of my friend, almost as a family, Dr. Peralta of Dominican Republic, already made one cystonostomy there. This picture here, as you can see, very good one. So first, we always need to back to the cadaver, to the anatomy. Because let me show you, okay. We're gonna just talk about the few systems we need to always remember, because they are the most common system we're gonna see, okay? So we're going to talk about the chiasmatic system, okay? About the limits. Why it's important is because the chiasma is our landmark. It's the biggest structures we're going to see after we open the dura and we go deep. At least is the landmark I use. The limits are the lamina terminalis. So you can see here, this is the system of the lamina terminalis is here. Is superiorly to the chiasmatic system. The carotid system is laterally, and the interpeduncular system is posteriorly. We need to remember the medial carotid membrane from the lateral wall of the chiasmatic system. Okay, we're gonna see here. You see here. I cannot point better here. Okay, yes, you can see here. Okay, this is the medial carotid membrane and form the lateral wall of the chiasmatic system, okay? You can see here, again. Okay, so again, you can see here, you can see very well here, chiasmatic. Here, chiasmatic, you can see here, chiasmatic system. Here, okay? And here again. Lamina terminalis here, you see lamina terminalis. Yeah. The system is not here, but remember, this is what we're gonna see. And you can see here, this is our corridor. This is the optical carotid pathway, the corridor we're gonna see. Again, this is the area gonna be the chiasmatic system, okay? And again here, lamina terminalis here. Remember, we will came from this side. I mean, from lateral, okay? Okay. And of course, the carotid system. This is very important one. It's bordered by the top of the dura mater of the anterior clinoid. I'm gonna see later if we need or we don't need to drill the anterior clinoid process, okay? So the anterior, the dura mater of the anterior clinoid process and the orbitofrontal lobe. Inferiorly is gonna have the cavernous sinus. Medially, as we remember, the medially, this system share the wall, okay, share a wall with the chiasmatic system, okay? And laterally is the uncus and limum insulae. You can see here the carotid system here again. You can see this very pretty picture. This is the chiasma, all chiasmatic system, all this carotid system, optical carotid pathway here, oculomotor nerve here. Okay. Again, well, here you see the chiasma here, and you see here all the membranes of the optical carotid system, the optical carotid pathway. Again, optical carotid pathway, you see here. Okay, I don't know what happened in the video. So, also we need to remember the system of Silvio's system here. Sometimes we're gonna open it. The limits we need to remember is the medial, we have the limb insulae, lateral, we have the frontoparietal, and the temporal overlapping cortex. Anterior, we're gonna have the frontal segment of the insula, overlapped by the opercular gyrus. Posterior, the gyrus angularis. Okay. So, the Systemostomy step by step. First, after we make the compressive craniectomy, we're gonna drill the spinal ridge until the orbitomeningeal artery we find it. That's gonna give us a lot of space. As you can see here, we enter for here and we drill. You see me also?
Yes, yes.
Okay, so we enter here, we make the compressive craniectomy, and we're gonna eat all the lesser wing of the sphenoid.
Oh, I'm sorry, we're not seeing you want to see an image, right?
No, I am showing the synthetic skull here. You see me?
Okay, because we're seeing cystostomy step by step. We're seeing the text.
You don't see my face.
No.
Oh, okay. I show you later. So we're gonna identify the superior orbital fissure and the orbitomeningeal band. We're gonna make division. We're gonna divide the orbitomeningeal band, and we're gonna mark the lateral edge of the superior orbital fissure. About the anterior clinoid process, well, we can drill it or we cannot, depend. It's gonna depend on how tight is the brain, how good are our skills. For example, I never drill it, the anterior clinoid process, I never drill it. And it's gonna depend. You can do it without drilling or drilling, okay? After that, we're gonna elevate the temporal lobe from the superior orbital fissure, and we're gonna exposing the anterior clinoid process, okay? Then we're gonna elevate the frontal lobe from the anterior clinoid process, and as I say, we can remove or we cannot. It's like what happened with the posterior clinoid process. The posterior clinoid process is gonna depend. If you don't have enough space for go to the Lilliquist membrane, you drill it. And also, if you have the skills enough and the material, and if you have the good equipment, yes, you can drill it. So after that, that was the extradural part. Okay, now we open the dura. We have different ways to open the dura. In the case I do is it's like a C shape with the base going basal. Okay, and then if we need more space, we open like that. So first, we identify the interoptic, optical carotid, and lateral carotid system. First, the optic nerve. The optic nerve is the structure I use as a landmark to know where I am. Later, we're gonna approach the Lilliquist membrane through the optical carotid window. And after that, after we open the Lilliquist membrane, we're gonna find, looking at us like, hello, we're gonna find the basilar artery. But if, you can see here, if the posterior clinic process is big and don't allow us, then yes, we do it. We drill it, and we're gonna open the liqueous membrane. Later, we place the drainage in the preponting system. In the case, the drainage I use is a pediatric drainage, okay? Nasogastric drainage, okay? Very small one, pediatric one. And later we close the dura. We approximate the dura and put gel foam or Sul-Gel around, okay? So as you can see here, we drill the lesser wing, we drill all the lesser wing of the sphenoid. And after we open the dura, this is what we see. Optional, we can open the sylvian, okay, or not. Again, as I told you before, we enter from here until here, okay? Until orbitomenial band. We can, yes, I made this part to have more space. But if you want to have more space and if you have the skills enough, yes, you can drill the anterior clinical process. You can see here, and you're gonna have very good position of all the elements, intradural elements, okay? So what's that? The liqueous membrane I mentioned. As you can see here, again here in the top, you see here. So we can define the liqueous membrane. It's like an incomplete arachnoid formation. It extends from the dorsum of the sella turcica to the mammillary bodies in the diencephalon. It's gonna separate the arachnoid membrane of the chiasmatic system, interpeduncular system, and the preponting system. It's gonna have two leaves, or two parts, gonna divide in two parts. One go anterior and superior. This is the diencephalic one, and the other one is the mesencephalic one. It's going inferior. You can see here, one here and one here. Okay, one diencephalic leaf, and the other mesencephalic leaf. So you can see here, this, because we open the encephalic membrane, okay, is thicker of the other two leaf. Small, frequently, we're gonna have a lot of perforation of this one. Again, you can see here, this encephalic, mesencephalic, it is here. This is, you can see here, this is liqueous membrane. We always need to be careful because after we open the liqueous membrane, what we're gonna find is the basilar artery. As if we are not careful enough, we can have some problem there, and this is something we don't want to have. So, as you can see here, you see here this very swelling brain after the compressive craniotomy, and after Systemostomy, you can see the drainage here. After drainage, you can see how the latch is the brain. And then, yes, and then you can put the bone back, the bone flap back. But no, not in all the times it's gonna be possible to put the bone back, okay? I'm gonna show why not in all the cases. Again, very swelling brain. You can see here it's very swelling brain. And after Cisternostomy, you can see the drainage, okay? You can see the drainage here, okay? So we're gonna present some cases. And after Cisternostomy, how they are. The first patient is a male of 41 years old. And the Glasgow Coma score admission is was 4. Yes, supposed to don't make the Cisternostomy because, as we say, before 5, not gonna have a good outcome. But we want to try to give the patient a chance, okay? Because who we are to don't give the chance to the patient and see. The patient in the 4 score was 6. was brought by the hospital ambulance. Okay, he was found unconscious in the street. Both pupils was not reactive. Marshall 6 and Rotterdam 3. We also use some different score because we want to compare how is the, because okay, we know the relationship of the Glasgow Coma score with the Cisternostomy, but what about the 4? What about the 4? We need to see, we need to make some more study to see how is the behavior of the 4 score with the Cisternostomy. Okay, you know, remember the full outline of irresponsiveness. And also Marshall of Rotterdam, we want to compare it. For that, we need more cases. To compare it, Marshall and Rotterdam, which one is best prognosis or indication to make the Cisternostomy, okay? As you can see here, you can see the CT of the patient. You can see a big dislocation of the middle line. Even you can see a face of one of, you can erase one of the ventricles and the lateral ventricles.
Manuel, you're muted. Could you please unmute Manuel? Manuel, can you hear me okay? Okay, there you go. You unmute, Manuel, unmute. Manuel, we can't hear you. Please unmute.
We can't hear anything.
Yeah, other people can hear me, right? But Manuel can't hear me, I guess. Manuel, can you hear me okay? Okay, I think he's happily commentating, but see, I can unmute him from my side, but he's got to unmute himself.
Okay.
Hello, Manuel.
Maybe you can send a message for her.
Yeah, I've sent a message. Let's see, what can I do? I can take over the screen, which is not a nice thing to do, but I think that's the only thing I have to do.
Yes, send anything.
Yeah.
Open.
Yes, John?
Manuel, okay, now we can hear you. Okay.
Now I can hear you. Yeah.
Okay, Manuel, go ahead. We couldn't hear you.
Okay. Thank you, John. Thank you.
You need to screen share again.
Okay.
You go back to the first surgery.
Okay, do you hear me?
Yeah. Is that right? Okay.
Okay. So, as you say, I was talking about the drainage, right? Do you understand me? Do you hear me?
Yeah. I hear it.
Okay. So, the second patient, 30 years old, as you can see, Glasgow Coma score at admission was 5. Scala 4, score 6, Marshall 6, and Rotterdam 3. Here, the quality of the picture is a little bit much better. As you can see here, so as you, again, you can see this is not the right suction, you see? The suction is huge. In some places, we don't have the right equipment, okay? But we open the system here, we open all the system, and we put the drainage. We put the drainage, even with loop, because we don't have the microscope. In this patient, again, we use the monitoring. And you can see here, the ICP was a little low, as it's supposed to be, but a traumatic brain injury with very, very low ICP, as you can see. This is the drainage here. So you can use the ICP monitoring, intraventricular, intraparenchymal, epidural, subdural, subarachnoidal. And one study we need to do is about monitoring this patient and with the Cisternostomy. We can use the intraventricular, or we can use subarachnoidal or subdural to see how fast this ICP is going down. You can use, maybe we can use the subarachnoidal monitoring at the same time we have the drainage there, and we can have the two functions, drainage, the system, and at the same time monitoring. We have the case 3, 35 years old patient, Glasgow coma score 6, the admission 4-8. The patient was brought to the hospital by ambulance, and history is falling from the 3rd floor. Right pupil non-reactive, mydriatic, Marshall 3, Rotterdam 3. You can see here the CT of the patient. As you can see here, since the beginning, we cannot put back the bone flap. This is one of the situations when we cannot put it back.
Hello, Manuel, you're on mute again. You need to unmute. Hello, Manuel, you need to unmute. You need to unmute,
Yes.
Manuel. Okay, you keep unmuting.
Okay. I share again. It's because when I put the video, with the sound of the videos look like I muted. Okay, do you hear me now? Do you hear me, John?
Yes.
So you can see here the patient, the patient authority the pictures. This patient went out from the hospital with some edema. He cannot open the eye very well, as you can see before, by the fracture the patient has in the orbit, okay? The case 4 is a patient of 30 years old, a female patient, Glasgow coma score 6 at admission, 4-8, Marshall 4, and the Rotterdam 3. You can see the CT of the patient, huge, very, very big middle line shift. As you can see here, we save the cuff because we're gonna put the bone back in this patient. You see the hematoma, and in the end, you see the drainage we put it. You hear me, John?
Yes, now we do.
You hear me? Okay, okay. Let me share my screen again, sorry.
Okay.
Okay. The case number 5 is a male of 66 years old, Glasgow Coma score at admission 5, 4, both pupils not reactive, Marshall 4 and Rotterdam 3. You can see here. In this case, yes, microscope, and you can see it's very different when we use a microscope. You have a lot of advantage. You can see, open the liqueous membrane, and when you open the liqueous membrane here, what you're gonna find? Yes, the basilar. Okay, it's like surprise. This is the basilar. We need to be very careful here. And then in that space, we put the drainage. Okay. So sometimes we have a very angry brain. For example, in this case, we use. I'm gonna take the time to promotionate. This is one instrument I developed. This is the instrument from make hemostasis of the scalp and at the same time make retraction. I call it hemostatic retractive forceps.
Uh-oh. There goes the audio again. Okay, I'm sorry about this. Manuel, we keep losing the audio.
Yes.
How can we stop?
It's because when I put the video, I don't know why I get mute.
Okay, I don't know why either. Okay, try it again.
Yes.
Okay. Hello, Manuel, we can't hear you. Manuel, no puede oírte. Well, problems like this happen. Okay, we just got to adjust to whatever's happening, just like in neurosurgery. Manuel, we keep losing your audio. Yeah, now we can.
But now I don't hear you.
You don't hear me. Wow. Can anybody else hear me? Mauricio, can you hear me?
Yes, we hear you.
Oh, okay.
Professor Bennett, we hear you.
Yes,
Manuel,
thank you.
we
can hear you, Dr. Bennett.
Okay,
It's
great.
because I don't hear you now, John.
Now we can hear you. Yeah.
Yes, we can hear you.
Can you hear me? Can you hear me, Manuel?
Yes, we can hear you.
Okay, Manuel, can you hear me? Manuel?
I don't hear you, John.
Oh, okay. Well, everyone else can hear me.
Yes, I can.
Yes,
yeah,
I can hear you as well.
Yeah, everyone else can hear you.
I hear you, Professor Bennett.
Okay.
I can hear you.
Can you play with your your audio? Turn it on and off your audio. Okay, I'll text you that.
I don't hear you, John.
I hear you, Bennett.
Okay. Go ahead, Manuel.
John, I don't hear you. Do you hear me?
Yes.
But I don't hear you.
Oh, okay. Can you? You need to play with the audio. You can't hear me, so I'll text.
Can you talk now, John?
I can hear you now.
It's strange. I don't know. I don't hear you.
Okay, let's just play with it. We'll get it. Yeah, let's see here.
Dr. Manuel, do you hear me?
Do you hear me?
Yes. Now I can hear you. Can
John,
you hear me? Yes, we can hear you.
I'm gonna leave and I'm gonna
start again, okay?
Okay, good.
No, I hear you. Now I hear you.
Okay.
Sorry, my bad. I don't know. Some technical issues.
Okay. You want to screen share?
Yes, yes.
Okay.
Okay, I was showing one video. I'm afraid to show you again because
Yeah.
I don't want to have this kind of issue again.
Yeah. Don't use the video. Don't use the
Okay,
video.
I'm gonna use the video. So
Yeah, just-
you can see here, this is the corridor we're gonna see in the Systemostomy. This is the main corridor of the principal one because we're gonna have the optic nerve, as I said, and the chiasma is gonna be the landmark. Chiasmatic system, we open here interoptic pathway. Then we go to carotid system. We open here the opticocarotid here pathway, Lilliquist membrane, and then we're gonna have the basilar, as I showed you in the last picture with the microscope. Also, we can open here, yes, we can open here carotid here, and the more lateral and superiorly, we can open the Sylvian system, okay? Hello, do you hear me?
Yes. Yes, we hear you.
Okay. So, the limitation. We have a hard area for the Cisternostomy. Sometimes we have a very big brain edema, very angry brain. We have a poor slope. Also, the learning curve. The learning curve of Cisternostomy is, of course, is higher than the compressive craniotomy. It's obviously. The prolonged surgical times can be 15, maximum 20 minutes. When we have the experience, you can make Cisternostomy in 10 minutes. Yes, in 10 minutes, because and of course, if the brain is not very swelling, in 15 minutes, you can make, maximum, you can make the Cisternostomy. It's open the cistern and put the drainage, 15 minutes. Technologies and equipment, yes, this is reality, because not in all the places we have the microscope. And also not in all the places maybe we're gonna have the surgical equipment, the Roton set, the micro instrument. So the question, can brain trauma benefit from the microsurgery? There is articles, for example, this article by Professor Franco Sarvedei, Angelos Kalas, Camille Rames, Kirolos, Tarikan, and Peter Hutchinson, who say rigorous evaluation is necessary. As all new technique, of course, new evaluation is necessary. We need to more Systemostomy to see, because it's a promise. The technique promise a lot, because the result, the decrease of edema, you don't need to wait 10 minutes, 1 day, 2 days to see it. You see, after you open the system, you see it's a fact. You see there, and the time. And there is when the magic happens. No magic, but the physiology happens, as I said before. After you open this pathway and all the systems going out, you can see in front of you, you can see how the brain relaxes. The brain relax. This is why the technique is promised a lot and can be changed. Can change how we make the trauma surgery since hundreds of years ago. So the quality of the evidence, most published Systemostomy studies are observational, retrospective, and not randomized. This is something we need to do. We need to do some prospective studies and randomized, okay? And a lot of them just run in a single center. For example, the cases we made here was in Podolsk Hospital, Udina Hospital also, in 2 different hospitals here in Moscow. Or this patient, and this study have a small sample, a small quantity of patients. So for this quality of evidence is generate and preclude the inclusion in the traumatic brain injury meta-analysis and guidelines. Okay, so the future cysternostomy must be robust ideally. They must randomize multi-center study. This is something I try to do, a multi-center trial, randomized about cysternostomy. And here I put you some studies about cysternostomy. As you can see here, the first one is cysternostomy, replacing the age of decompressive hemicanectomy. The level of evidence you can see is 3, 3, 4, and 3. There you can see the amount of patients is 468, 70, 77, 50, 18. So we need more patients because the studies, we need randomized trials, okay? Randomized trial in different centers because we have retrospective. The majority of them, they are retrospective, okay? Maximum is a double center. The conclusion. So the cysternostomy is a new technique for the treatment of traumatic brain injury and decrease in the act in front of in the surgery the swelling of the brain. So the cysternostomy is addressed for following from more rigorous studies. Cysternostomy is a fair price to pay to alleviate the current economic and social burden of traumatic brain injuries in developing nations, when the rehabilitation is very, very expensive. The right equipment is rigorous necessary because if we don't have the microscope, it's not so easy to make the cysternostomy, okay? And we can have some complication. We need the micro instrument also for making the cysternostomy, right equipment. So combine the cysternostomy with the decompressive canectomy has been shown to have very favorable effect on mortality and the duration of the ventilation in the patient in the ICU state. So special thanks to Anton from the Podolsk Hospital, and also to Nikita, very good friend of mine, who we made cysternostomy together, and we have very good results there. Also to Professor Cherian, because I learned the technique with him when I was in India. And here, this is the reference I left you from some of the studies I present here. Yes, John?
Okay, very good, Manuel. Thank you for your efforts. Let's start off with a question from Dr. Deepak from the Ukraine. He says, very nice presentation, especially the anatomy part. My question is that, how good or how is the outcome of the use of cisternostomy in TBI patients? Isn't it better to close sooner after removal of hematoma rather than opening cisterns? Or is there any clinical trial comparing the outcome?
Sorry, repeat me? Repeat me the beginning.
Okay, I'll start at the beginning. Okay, my question is, how good or how is the outcome of the use of cisternostomy in a TBI patient? Isn't it better to close sooner after removal of the hematoma rather than opening cisterns? That's a pretty big question. Did you get that?
Okay, I'm ready.
Can you see it? It's written in the chat.
Yeah, yes, I'm checking. It's better to close sooner after removal.
Hello, can you hear me?
Yes, I hear you. I hear you.
Yeah, I think his question is about not to do cisternostomy, but the answer that cisternostomy should be done because the brain edema will not subside after removal of the subdural hematoma.
He's asking me. Okay, now I understand. If we make the cisternostomy before remove the hematoma or after?
No, he means that there is no need for cisternostomy, as I understand.
In case of collecting hematoma or surgically treatable hematoma, I guess.
Repeat me? It's because I don't catch a question.
Okay. Well, the question is written in the chat. Can you see it, Manuel?
Yes, I see it, but because okay, he say it's better to close sooner after removing hematoma rather than open cistern.
Yeah. Okay, Deepak, can you tell us, Deepak, are you there? Can you enlighten us on the question or expand on what you are asking? I don't know if he can talk. Okay.
Yes, he can make the question directly. It's gonna be good if he can make the question directly.
Yeah, but some people don't like to talk, use the audio. Okay, we'll go on to any other question. Hopefully we'll come back, Dr. Deepak. We're not ignoring you. Okay,
Okay, I have a question for.
Go ahead,
Yes,
thank you for us.
Can this Cisternostomy and TBI be done with the endoscope? Any trials?
Well, I don't know. It can be possible. I never see it. And can be good if it can be done. This study like this is gonna be very good. It's gonna be very good. But for that, Systemostomy is new technique. We need to promote the Systemostomy and see if people can have this kind of idea and see what happens.
Mm-hmm.
But if you can do it, if you can try, it's gonna be awesome.
Okay, can it be? Can we use a way or a pathway through interhemispheric fissure?
But to open, because if you go to interhemispheric, but in which system you want to get there?
You will go directly to the Liljeqvist membrane.
Well, it's possible, yes. But for example, what and the hematoma and the trauma then? How are you going to open?
The hematoma, you can remove it by a bare hole.
But if you have a big subdural hematoma, for example, more than 12 or 15 centimeters, let's say, I cannot remove by the bare hole. You can?
You can use one or two bare holes and suction it.
Well, I'm gonna be glad if you can do it and show it can be something very promising, It can be something very good. But yes, if you can open lamina terminalis, and you can open lamina terminalis and then go laterally and open the optic chiasmatic system, and put the drainage interoptic in the interoptic pathway. It can be good.
Mm-hmm. Thank you.
To you.
Okay, more comments, questions from anybody? Feel free. We've got the time.
Yes, I have a question. Okay. Yes, my question is: after removing hematoma, is better to open cister? Yes. After you remove the hematoma, then you open the cisterns.
Okay,
is the
good.
question of that of
Dr. Deepak. Yeah.
Yes, Deepak, Dr. Deepak. Yes.
Great. From the Ukraine. I'm not a neurosurgeon, Manuel, but is it Cisternostomy just starting to be used in Russia?
Yes. Well, we are the first. We are the first who made the Cisternostomy here. For that, we need to promote the Cisternostomy.
Can you tell me where it was in Russia, in Burdenko?
I was in Burdenko, but as you know, Burdenko don't make trauma. I was in Burdenko with Professor Konovalov in 2019, but I was in spinal studio with him. But as you know, Burdenko don't make trauma. Like they don't receive skora pomoc.
Oh, okay. Wow. Such a big center. No trauma. Wow.
They attend some patient after trauma, but not the
Primarily.
one who,
Trauma.
yeah, the one who has said trauma, the big one center of trauma is the Schizofoskaya. It's
Polypharmacy Institute.
yes, it's very good one. After maybe one day, for that we need to talk with Professor Krylov or Professor Green to talk about Cisternostomy and try to implement there, because this center received more than 4 patients per day in traumatic
I
brain
worked
injury.
in Palenova.
I don't know which center is this.
Palenova in St. Petersburg.
Ah, okay. Well, you can join to us and make some Cisternostomy cases and see the results, and we can make a big study here.
That was 22 years ago.
Ah, 22 years ago.
I finished there, yes.
Ah, okay. And now you are where?
I am in Jordan.
Oh, okay, good.
Yeah,
With Dr. Sabea.
yeah, he's next to me.
Oh, okay.
Okay.
Yeah, he has a webcast every second Wednesday, as you probably know.
Yes, I have another question. Yes, the question is, if the result of the Systemostomy was some trauma. The question is, this is better to open, is a direct question. Is it better to close the...
Actually, we cannot see the questions here.
Yes. Daniel, can you make the open question, please? It's from Daniel Encarnacion. If he can make the open question. We have the same last name, John, but we are not family.
Well, hey, you know, Manuel, I have another. I'm not a neurosurgeon, but
Yes.
is in order for a neurosurgeon to do an operation like cisternostomy, it has to be approved by the staff because it hasn't been done at that hospital. Is that how it's done?
Yes. Well, it's because it's something new. It's something relatively new.
Right.
And of course, the head of the department, for example, need to be involved on what is that. Because, for example, some people say, the problem of the Systemostomy is the learning curve, because in some places the emergency patient, the trauma patient, they can in the night, and in the night there are some residents, and the residents are the one who made the cases.
Right.
But something we need to, because if people say, yes, the vascular surgeon of the skull-based surgeons cannot go in the night, in the 1, 2, or 3 in the AM in the night for Systemostomy cases. We know we are talking about some lack of empathy. If the doctors say, I know, I don't go there because it's too late.
Right.
Because if the Systemostomy at least can give a little better outcome, is some chance we need to catch. What prices we want to pay? Yes, to use the microscope, maybe 15 minutes more of surgery, learn a new technique. But if the patient have a little, even 1 point of Glasgow better of outcome, yes, I think we can do it. We need to do it. If that can improve the patient at least a little bit, yes, we need to catch that chance.
Okay. More comments or questions? Don't be afraid to ask anything.
Have you learned any Russian?
Sorry?
Have you learned Russian language?
Yes. I even married here.
Oh, хорошо.
To a Russian girl, right?
Yes, my wife, she's Russian.
Yeah, we have a few Latinos here, Manuel. Хорошо. Dejme молоко.
Yes, it's milk.
My brother learned the Russian. He used to speak it all the time at the dinner table.
Russian is hard. It's very hard. It's very hard language. Very hard.
Yeah, different alphabet, huh? Like Chinese. Okay. Let's see. Any more comments or questions? Okay, we have. We'll meet a few Latins after the webcast, but
Well, for example, Nikita from Podol, he's here. Nikita. For example.
Hello, Manuel.
Yes, Nikita, how are you? If you have any comment about Systemostomy and the outcome we have.
Yeah, our patient is getting better. He was wait after sedation and wake up. The drainage from the system was removed yesterday. On control CT, we had very good results.
Yes, Nikita, thank you so much, Nikita. Nikita is my friend with the one I performed Cisternostomy for those. Nikita, for example, made his first Cisternostomy. Was 2 days ago, right, Nikita?
I'm on duty now.
Yeah, yes. I say you made your first Cisternostomy 2 days ago.
Yeah.
That's Saturday.
Oh,
yes.
wow.
Yeah. That was made by my hands.
Oh, wow. This is exciting. Medicine happening now.
Yes.
And Manuel, great thanks.
No, to you.
A good honor to be in your presentation. Thank you for your
my
help.
friend. Thank you.
Always.
Thanks to you.
If some cases will be happen here.
Well,
Thanks again.
Nikita, you can do a webcast in Russian if you want. If you want to present in Russian, we can do that. We can arrange it if you want. Okay, just think about it. Okay.
Okay, that's very interesting.
Okay.
Yes, John. That's a good idea. We can present the Nikita's cases of Systemostomy in Russia, and that way we can promote more, and more people can be more interested.
Maybe it's the right time to say, starting Monday, we're going to have webcasts with Dr. Borba and Dr. Sufianov of Tayuman. So we're going to start to have regular webcasts from Tayuman with Dr. Sufianov.
In Tuning.
Yeah, Tayuman. How do you pronounce it? Tayuman.
Yes, Dr. Mansur Ali.
No, Dr. Sufianov.
Yes.
Yeah, well, so Monday we start the webcast from there.
Oh, really?
Yes, Monday. Probably about the 4 o'clock in the afternoon. It'll see in Russia it will be 3 or 4, but just watch on Neurosurgical TV. You'll see the announcement. Dr. Borba is getting involved from Brazil with Russia. So
yes. Borba came many times here. I meet him several times there in Tumen.
Oh, really? Oh, okay.
Yes. I met him in 2018 and 2019 here.
Yeah, I love broadcasting him. During one of the webinars, he kept waking up the residents. The residents were falling asleep, so he kept stopping his presentation, saying, "Wake up!" It was funny. It was funny because I can relate. Being a resident, of course, you sit down, you have a cup of coffee, you're tired. Naturally, you're gonna doze off once in a while. Okay, Dr. Mansour, you have a comment or question? Your hand is raised there. Can you hear me, Mansoor? Or you can just type it in the chat, because I see you have your hand up. So what is your schedule, Manuel? Are you're going to stay in Russia? Or are you going back to Dominican Republic, or what are you going to do?
I go to Dominican Republic. I go to my wife, my daughter to Dominicana, because I think in Latin America and in my country I can be more useful.
Okay.
I have some ideas, and I think I can give to my country. It can be something good.
Okay, what year residency are you now?
I am in the end of the third year.
Oh, okay. So you have, after you finish, how much longer to finish?
2 years more.
Oh, okay.
No, 1 year and a half more, because I next month I'm gonna be in the fourth year. So let's say 1 year and a half more.
Okay, because we have a few Latins here now. I'd like to introduce you to Mauricio. Hello, Mauricio. Mauricio is from Paraguay, and he's part of the group that's helping promote our webinars. Mauricio, I think Manuel is going to do a presentation about a few things. He could do one about cisternostomy, and also about the prototype of the brain that he's making. And you can describe that to Mauricio, Manuel, if you
Yes,
want.
of course, of course. I'm gonna leave my email here. I can to Mauricio. I can explain you what about the brain models I am making for the training, vascular brain models, third ventricle models with ventricles for maybe third ventriculostomy. And the vascular one you can make bypass, and you can make also aneurysm clipping. Also, you can have model with tumors to remove the tumor.
Very good. Well, I'm glad Mauricio could see a Latin in Russia. You know, in neurosurgery, you have to travel for education. You know,
That's
it's
true.
good. You have to travel. And Mauricio, you may be leaving Paraguay someday and going to Japan, Russia, China. I mean, when you train, I'm very impressed with the neurosurgeons, the big ones. They've traveled. They've done fellowships in Canada and England, and you know, they travel anywhere they can go to get a good education. Mansoor, I see you're on. Do you have your comment or question? Go ahead. You have to unmute, Mansoor. Unmute your microphone. Unmute, Mansoor. I can see you talking, but you.
Yes, sir. Good afternoon, everybody, sir.
Yeah, okay.
Thank you very much for organizing a wonderful session. I have few questions, sir.
Yes, please go ahead.
Number one, sir, all the 4 patients, I think the Glasgow Coma scale was more or less reasonable, 5 or 15, sir. Except few, one of the patient who had 6 by 15, 6 over 15, and other most. Sir, I want to know, sir.
Okay, we're having some audio challenges.
Yes.
Can you? That's okay. This technology sometimes has problems. Can you text the question, Mansoor? We couldn't hear it. You want to try to ask again? Go ahead, ask it again, Mansoor.
Hello.
Yes.
Yeah, try again. Yeah, just having a little difficulty with audio, because when you do audio and video at the same time, it really demands bandwidth. So I think Mansoor is going to have to text the question.
Hello.
Yes, I hear you.
Okay.
I hear you, doctor.
Go ahead. Try again.
Yeah. Sir, the question is, sir, all these patients underwent cisternostomy.
Yes.
I wanted to know how this procedure or this surgical approach is superior to decompressive hemicraniectomy, which is superior, and why, sir?
Well, as you know, the compression craniectomy just open and give space to the brain to relax. Just give space to the brain to relax. If the brain swelling a lot, if the brain can go and have even cerebral fungus. All the brains can go outside in the margin of the craniectomy. So the decompressive craniectomy just give a space. Just give a space to the brain, like do whatever you want. But the Systemostomy, what it do is attack microscopically the reason why the brain is swelling. Because when you make the Systemostomy, what you avoid is that swelling go out. Because you take all the CSF. Because the brain swelling, one of the reasons is all the liquor, all the CSF go in the parenchyma. But when you open the system, you avoid this swelling of the brain. So, and when you combine both of them together, the student's results prove is have much better results. But if you make the Systemostomy, now you avoid the swelling, you put the catheter, and then you can put the bone back, and you can have also good results.
Okay, sir. Second question, sir. How many patients developed SIADH after surgery, sir?
Well, no one of the patient, but the first reason is because our universe is only 9 patients. The first reason is we only have 9 patients, and where we perform Systemostomy. For see that we need to have more patients.
So I mean to say, sir, none of patients who underwent Cisternostomy. Hello.
Yes, I hear you. I hear you.
None of them developed SIADH after surgery.
No, one of them. No one of them. One of the reasons. One of the reasons I cannot tell you like it's because the Systemostomy. No, to be honest, I cannot tell you that. The main reason is we have only 9 patients. We don't have enough universe to see.
Okay, sir. Okay, sir. One more thing is, sir. One more last question. Usually, in the initial management of traumatic brain injury, in order to reduce the cerebral edema, which drugs we use commonly? Mannitol, glycerol, and steroids. What do you use?
Well, for example, here, because here they use usually mannitol. We use mannitol, and in only one case we use hypertonic solution. But usually here in the Russian Federation is mannitol.
Mannitol. We do not use glycerol.
No,
we do not use glycerol. What about steroids, sir? What about steroids? Steroids, corticosteroids, prednisolone, dexamethasone. How?
No. We don't use it in any case.
We don't use it.
No. In any case.
Okay. One more question, sir. All these patients, after going Cisternostomy, do we give them anticonvulsants? Which anticonvulsants we prefer? How long should we give?
Sorry, repeat me.
All these patients, after going through the Cisternostomy, do we put them on anticonvulsants?
Yes, of course. To all the patient, for low here, to all traumatic brain patient, anticonvulsant. Yes. For example, the patient they take the normal management as a traumatic brain injury. They take the usual management. The only change is in the surgery time is about the Cisternostomy, and after that, the patient can be less time in the ICU. But for that, we need more patients. But the management of the patient with Cisternostomy is the same as you're gonna make from descompression craniotomy, the same. Hello.
Okay.
Hello.
Yeah, we can hear you.
Just a last question, sir. What? Just one
Oh,
question.
Monsieur, you can ask as many questions as you want.
No, sir. Thank you, sir. Thank you so much, sir. Thank you so much. Last question, sir. All these patients who undergo cisternostomy, which anticonvulsants we use? Do we use diphenylhedantoin? Do we use levetiracetam or some other, sir? And how long should we do?
Well, for example, if we have a big patient with a big traumatic, we can use barbituric, for example. We can use barbituric usually in some patient here.
Phenylbarbitone.
Yes, usually.
Phenylbarbitone. What
or
about
valproic? On some of them we use valproic acid, for example.
Valproic acid. Okay.
Yes, the most usually we use valproic acid.
Okay.
And some of them, because something you need to know is about the money. We use we can use midazolam, but valproic acid is the most common we use.
Okay. What about diphenylhedantoin, sir? Dilantin. What about dilantin, sir? Don't we use dilantin? Diphenylhedantoin.
No. Only we use the valproic acid and midazolam in some cases, but more usually valproic acid. More usually here.
Okay, sir. What about carbamazepine?
But we use, but more usually here we use from spinal in surgery in traumatic brain injury, like not to take in home. Yes, we use to taking home. Yes, we use carbamazepine to taking home. After after the patient go out from hospital, yes, they can be taking carbamazepine, but not in hospitality.
Thank you, sir. Thank you so much. Thank you, sir. Thank you so much.
Okay, if you have more questions, you can ask later, Mansour. We appreciate your input. We have a doctor from Afghanistan on the panel, Ahmad Fawad. I don't know if you can talk now, Ahmad, but you're welcome to greet anybody. Let's see here. Any more comment? Okay, Manuel's email address is on the chat. If anybody wants to report a case or wants to talk to Manuel about questions you may have after the broadcast, his email's in the chat. So just grab that email if you want. Let's see here. Got some more messages. Oh, okay. Okay, from Israel. Let me see if from Israel Ramirez. He asks, "How long are you doing follow-ups in your patients?"
Oh, yes, Israel. How are you?
Israel Ramirez.
From Israel. Israel from Israel. Are you there, Israel?
Yeah, I'm here.
Yeah,
Great presentation, man.
John, do you know? I know Israel from university.
Oh, from where? Where? From Dominican?
Yes, yes.
Oh, bienvenidos.
He was one of my boss in the anatomy teacher. He was one of my boss when I entered there.
Oh,
really?
Okay. Welcome,
Yes.
Israel.
Thank you. I'm currently in Israel, so I'm far away from the Dominican Republic. But thank you. Nice presentation, by the way, Manuel.
Thank you, sir. Yes. So your question is for how long time I'm following the patient?
Yeah.
Well, for example, the second patient I present, unfortunately, that patient died. Of the 9 patients we have, 2 of them they already died, and 2 of them we have a very close up to the patient because they are programming to make the cranioplasty. 2 of them cranioplasty. 1 of them we put the bone flap, and yes, we'll follow up this patient. Supposed to 2 of the patients supposed to be there, supposed to go back to the hospital at least in September. The patient at least 2 months after the surgery is supposed to go back. The next follow up.
You have 2 patients. You have
Sure.
2 patients that you have 2 patients and they underwent decompressive and they're waiting for canoplasty. So why in this case, why do you decide to do a cysternography in this case? Why do you do it? The point of the point of the surgery you're describing is to release the CSF, to lower the ICP, and to improve the prognosis.
Yes.
It's the same that theoretically the decompressive does. So what's the difference? Why to do both?
Well, for example, the difference is the difference is in the cysternostomy, you avoid the brain swelling. In the descompressive craniectomy, you don't avoid the brain swelling. You just give enough space to the brain to relax. And the second part is in the cysternostomy, after the brain swelling and after the brain relax, you can put the bone back. And that's one of the main issues also, because if you put the bone back, in terms of money for the patient on incoming country and not developing country, is gonna help a lot, because the patient don't need, and not only incoming country, any kind of patient in any country. If you avoid the patient, the pay for another for the cranioplasty or titanium one, for example, and go under surgery again, all this stress, the risk. Yes, the quality of the patient can be much better.
I get it. So, okay, thanks. I hope to see a series with more patients to decide.
Yes, yes. The idea is to make more patients, because with the 9, for example, the question answer say, yes, they are good question, but we have only 9 patients, and it's not enough universe to answer properly all these questions.
Yeah,
okay, great.
Okay. Yeah, you need a China connection to get the numbers.
Yeah, they got the numbers. They got the numbers. All the numbers they have.
Well, they have a group in China doing cysternostomy, right?
Yes.
Yang Hong, have you connected with him, Yang Hong?
Yeah. I meet him. I meet him in Pakistan.
Oh, okay. Does he have a lot of cases that he can look at?
Yes. He have a lot of cases. But the idea, for example, I don't include any of the patients I made there in India to avoid the bias, you know. So to avoid the bias, because I was with Professor Cherian, and to avoid the bias, I don't include the patient I make with him. I try to include patients in here from different hospitals. It's gonna be good if we can make, for example, in Latin America, we unfortunately, it's a pity, but we have a lot of trauma cases. You know, Latin America have a big problem with the motorcycle. People don't use the proper equipment. So we have a lot of trauma, and we can make a huge study about cysternostomy and see and solve a lot of questions. For example, the question Dr. Mansor say, yes, we can solve this question with a good amount of patients in different hospitals and in different countries.
Okay, someone's asking for your email. Let me get it. Okay, Amir, I'll give it to you again. I'm putting once again, Manuel's email on the chat. Okay, make sure you see it, Amir, right there. I just put it on the chat.
Yes, yes, sir.
Yeah, okay.
I cannot find Mr. Manuel's email.
Oh, did you get the email, right?
No. Can you?
Can you see it in the chat? It's in the chat right there. Can anybody else see it in the chat? Manuel's email address. Can anybody else see it at all?
Oh, yes. Thank you.
Okay.
I
Yeah,
found
sure.
it.
Okay, you got it? Make sure you get it before we close, because it disappears once we close. Okay. How are you dealing with the winters in Moscow, Manuel?
Well, it's getting cold again. It's getting
Well,
cold again.
it's not cold like that in Dominican.
Of course, no, never. Never is gonna be.
If there's no snow in Dominican, right? Never, no snow,
No.
ever.
Never. No, it's it's Caribbean.
But you stay indoors all the time, right? You're in the hospital all the time. So
Sorry?
you're in the hospital all the time.
Well, if you want to learn, you need to work.
Yeah. So the life of a doctor, it doesn't matter if you're Dominican or Russia, you're inside.
Exactly. I came very far from this is my home. Now this is my home. But I came from very far and not for sitting.
Okay, very good, Manuel. Okay. So yeah, if you want to arrange a webcast in Russian about cysternostomy, we could do that if you want.
Yes, we're gonna do that.
If your partner wants to help you, Nikita wants to help. Yeah.
Yes, it's gonna be very good. And to Radamés Ramirez Cano from Mexico. Also, I am planning to make some multi-center pilots and see what we can do with cysternostomy and what results can be there. I hope all of you can join and my mail is there. We can talk about it and see what can happen. Also to the participants, we can make some pilot with cysternostomy and see.
Okay. Okay. Any closing remarks for anybody? Want to say anything before we close? But okay. Yeah. Thank you for coming, Amir. Thank everyone for coming. We're gonna stay here. I'm just gonna stop recording, but please stay here to network. Thank you very much, everybody. Okay. We stopped the recording.